A basic dictum in the management of cardiac arrhythmias may be worth mentioning at the outset. While managing tachyarrhythmias, expect them to go on for bradyarrhythmias and vice versa. So be ready for both in any given patient. Moreover, bradyarrhythmias and pauses can precipitate pause-dependent tachyarrhythmias like polymorphic ventricular tachycardia or torsades-de-pointes, a life-threatening arrhythmia which usually occurs in the setting of QT prolongation. What causes cardiac arrhythmia? Myocardial factors like ischemia, infarction, and myocarditis, autonomic imbalance like sympathetic and parasympathetic overactivity or underactivity, electrolyte imbalance like hypokalemia and hypomagnesemia, hypoxia, drugs like antiarrhythmic agents and psychotropic agents, genetic disorders, channelopathies like Brugada syndrome, long QT syndrome, and short QT syndrome. Common supraventricular tachyarrhythmias: atrial fibrillation, atrial flutter, AV nodal reentrant tachycardia, atrioventricular reentrant tachycardia, atrial ectopic tachycardia, pre-excitation syndromes combined with atrial fibrillation, multifocal atrial tachycardia. Common ventricular tachyarrhythmias: ventricular tachycardia, monomorphic or polymorphic, ventricular fibrillation. Investigations in a case of cardiac arrhythmia. ECG is ideally recorded during the arrhythmia in addition to a routine baseline recording. Holter monitoring used for 24 to 48 hour monitoring or wireless patch monitoring. External loop recorder is an event recorder which monitors continuously and records events. Implantable loop recorder can be used for long-term recording up to 3 years. Head-up tilt test for evaluation of vasovagal syncope. Echocardiography to exclude structural heart disease. Invasive electrophysiological studies, conventional catheter mapping and programmed stimulation. Cardiac mapping using new modalities like 3D mapping. Management of atrial fibrillation. Options in atrial fibrillation are rate control with anticoagulation versus rhythm control. Termination can be achieved by synchronized DC cardioversion. Direct current cardioversion is indicated in atrial fibrillation if there is hemodynamic compromise with hypotension, angina, or pulmonary edema. Rate control can be achieved by digoxin, beta blockers, or non-dihydropyridine group of calcium channel blockers like verapamil and diltiazem. All these agents can be given orally as well as intravenously depending on the situation. Rhythm control can be achieved by amiodarone, flecainide, quinidine, sotalol, or ibutylide. Anticoagulation has to be initiated with heparin and maintained on warfarin with a target INR of 2 to 3 or non-vitamin K oral anticoagulants, NOAC. Long-term anticoagulation is decided based on the risk factors using standard scores. Anticoagulation prior to elective cardioversion is usually given for 3 weeks if AF has presumably lasted more than 48 hours. Alternate option in case of need for early cardioversion is transesophageal echocardiogram to exclude left atrial thrombus. Management of atrial flutter. If there is acute hemodynamic collapse or heart failure, emergent synchronized DC version is needed. Energies less than 50 joules may be sufficient as atrial flutter is highly sensitive to cardioversion, being a macro-reentrant arrhythmia. Atrial or esophageal pacing may also be able to terminate atrial flutter. Intravenous ibutylide has a success of 76%. Rate control can be achieved by diltiazem, verapamil, beta blocker, or digoxin. Anticoagulation protocol as for atrial fibrillation. Management of supraventricular tachycardia. Vagal maneuvers like carotid sinus massage or gentle pressure over the eyeballs may be initially tried. In an infant, the dive reflex can be activated by placing ice packs over the face. Adenosine as a bolus injection is very useful in terminating an episode of supraventricular tachycardia. If a second bolus at a higher dose is required, it should not be an add-on dose but a higher dose as the half-life of adenosine is very short. Adenosine is contraindicated in asthmatics as it can induce bronchospasm which can persist up to 30 minutes. Intravenous verapamil, diltiazem or esmolol are other options for termination of supraventricular tachycardia. Management of multifocal atrial tachycardia. 3 or more P waves with different morphology at a rate above 100 per minute qualify for a diagnosis of multifocal atrial tachycardia. ECG of multifocal atrial tachycardia resembles that of atrial fibrillation and flutter. Multifocal atrial tachycardia occurs in seriously ill elderly individuals, mostly in those with chronic obstructive pulmonary disease. Treatment is that of the underlying condition. Management of ventricular tachycardia. Amiodarone is the most commonly used agent. A word of caution is needed regarding amiodarone infusion. Occasional serious acute pulmonary toxicity can occur and hence the duration of therapy should not exceed 24 to 48 hours except when absolutely necessary. Maintenance with oral dosage of amiodarone is necessary for recurrent ventricular tachycardia. Lignocaine intravenous bolus followed by infusion was the sheet anchor of treatment of ventricular tachycardia earlier. Lignocaine is mostly useful in VT due to acute ischemia. Ventricular tachycardia with hemodynamic compromise is treated by synchronized direct current cardioversion followed by suppressive therapy. Role of magnesium in the treatment of cardiac arrhythmia. Intravenous magnesium is a drug which is often very useful in the management of polymorphic ventricular tachycardia. Deficiency of magnesium is associated with cardiac arrhythmias and can precipitate refractory ventricular fibrillation. Magnesium deficiency will also hinder replenishment of intracellular potassium as magnesium is a cofactor for the enzyme involved in potassium transport. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.